Hello everyone. So today we'll talk about this very important topic called hypertension. So we all know that hypertension is quite prevalent in our society. Almost everyone knows someone who is suffering from hypertension. So let us start this topic. First of all, what is the prevalence? Okay. So in US, according to a survey, 75 million population is suffering from hypertension. Clear? Now next is the most common cause of death. It is an important MCQ. It is most common cause of death in hypertensive patient is because of CVS mortality. Okay. Now, what is the definition of isolated systolic hypertension and what is the definition of isolated diastolic hypertension? So, isolated systolic hypertension it is more common in elderly because of the stiffened vessels. There and the criteria is if SBP is more than 130 while diastolic BP is less than 80. Okay. So this is isolated systolic hypertension. Then we have this isolated diastolic hypertension also, in which systolic BP is less than 130 while diastolic BP more than 80. Okay. Then let us discuss about arterial waveforms. In normal population and in elderly population in which vessels got stiffened. So we'll discuss about arterial waveform in aorta, that is elastic artery. We know that first wave in a vessel is antegrade wave. Okay? And this is because of the ventricular contraction. Then we have the second wave. This is retrograde wave, and this is because of the recoil of elastic artery. And this point where they contact is in diastole. And when they contact in this phase, there is slight increase in BP here. Okay? This is a normal pressure curve. Now in elderly population in which there is increased stiffness of the vessels, the curve looks like this. So we have this anterograde wave similar to the previous one, but retrograde wave, which is due to the recoil, comes early because of the stiffened vessel. So this wave would come somewhat early. So their merging is somewhere in systole here. So there would be increase in BP here. And since this merging is in systole, so there is isolated increase in systolic BP. Okay? Now, in normal condition, this merging occur in diastole, but in stiffened vessel, this merging occur in systole, leading to isolated systolic BP. Now, isolated systolic hypertension is more dangerous because it leads to increased cardiovascular mortality, while isolated diastolic hypertension don't increase cardiovascular mortality. Okay? Why isolated systolic hypertension leads to increased cardiovascular mortality is because when there is increased systolic pressure, the coronary blood flow decreases. Okay. Now, next slide. Next slide is about ACC or AHA guidelines for classification of hypertension. We have other classifications too like JNC, but we'll discuss only ACC AHA classification here. According to this, the normal BP is when SBP is less than 120 or diastolic BP is less than 80. Yeah. Now, second condition is elevated BP, which is when SBP is 120 to 129 and diastolic BP is 80 to 89. Then we have a stage 1 hypertension in which SBP is 130 to 139. So here the DBP is less than 80. In stage 1, the systolic BP is 130 to 139 and diastolic BP is 80 to 89. In stage 2, SBP is more than 140 and DBP is more than equals to 90. Yeah. Now, when the BP is normal, we don't have to do anything. In elevated BP, what we do is non-pharmacological therapy like exercise and diet plus follow. In stage 1, again we do non-pharmacological therapy plus follow-up. Plus if ASCVD score, that is the score to predict the increase of cardiovascular disease. If ASCVD score is more than 10%, then we will add one pharmacological therapy. In this condition, we will start with only one drug. In stage 2 hypertension, we'll give non-pharmacological therapy plus pharmacological therapy. And in pharmacological therapy here, we'll start with two drugs at low doses. We will start with two drugs. Now, measuring of BP. This is a very important part. That's how to take BP properly. Measuring BP in appropriate. Yeah. So in this, the first thing to take care is that the patient should rest for at least 5 minutes before having his BP checked. Okay. Suppose if a patient comes to us in OPD, we'll have him rest for 5 minutes before taking his BP. Second thing is that the caffeine and cigarette should not be taken before 30. Then another point is legs should be uncrossed. Another important point is that patient should be seated with arms at the level of heart. Patient should sit with arms at the level of heart. Okay. Another important point is that inflatable cuff should cover 80% of arm circumference in length, and it should be 40% of arm circumference. This is the measurement of a appropriate BP cuff, and it should be tied 3 cm above cubital fossa. That is, lower point should be 3 cm above cubital fossa. Another point is that the first audible sound, that is para cough, first correspond to systolic BP, and last sound para cough fifth corresponds to diastolic BP. Here. Now, next slide is about BP monitoring. We have three types of BP monitoring, that is ambulatory BP monitoring, home-based BP monitoring, and office BP. So office BP monitoring is something that a patient comes to us in OPD or our office and have his or her BP checked. So this classification, that is ACC-AHA classification, is based upon this office BP monitoring. Okay. So this cutoff is for office BP monitoring. Now, what is ambulatory BP monitoring? Ambulatory BP monitoring is something very advanced in which a device is attached to the patient and it will keep on checking the BP of the patient at regular intervals. That is, in daytime it will check after every 15 to 30 minutes, and in night time it would check every 30 to 60 minutes. And a graph is drawn in your phone. Yeah? So it is recent technology. It is quite helpful in diagnosing mass hypertension. Yeah. And the cutoff for hypertension in ambulatory BP monitoring is if 24-hour BP average comes out to be more than 125 by 75, or daytime average comes out to be more than 130 by 80, or nighttime average comes out to be more than 110/65. Then we can call the patient as hypertension. So the criteria we have discussed here is for office BP monitoring only. For ambulatory, we'll use this criteria. For home-based BP monitoring, the home-based BP monitoring is used for two things. That is first for masked hypertension, second is for white coat hypertension. And in home-based BP monitoring, if BP is more than 130/80, two occasions, two readings, then we can classify it as hypertension. Yeah. Now, office BP monitoring we have already discussed, and it should again be at more than two occasions, more than two readings. Yeah. Then we can diagnose the patient as hypertension. Next slide is some definitions. That is, what is masked hypertension? In masked hypertension, patient would be having elevated ambulatory BP or home-based BP, but normal office BP. Clear? These are more common in patients of CKD, and these are associated with increased cardiovascular mortality. Okay. Now, second is white coat hypertension. In this, the patient becomes anxious whenever he comes to the hospital or our office, which leads to increased office BP monitoring, but normal home-based BP and ambulatory BP. So definitely these patients are not hypertensive. They just become anxious whenever they come to the hospital or our office. So this would not lead to increased cardiovascular mortality. Yeah. Now the third important point is non-dippers. What happens is that in normal individuals, BP falls 10 to 20% during night. This is a normal phenomenon and this is known as dipping. We can diagnose this on ambulatory BP monitoring, as ambulatory BP monitor measures BP throughout the night every 30 minutes. Okay. So what happens is, suppose the BP doesn't fall during the night, then we call these patients as non-dippers. Okay. So a hypertensive patient can be a dipper, non-dipper, or a raiser. Okay. So dipper is that a hypertensive patient, although the patient is hypertensive, but there is normal dipping during night. And in non-dipper, the patient is hypertensive, but the nighttime dipping stops. Okay. So in this condition, since there is no dipping during night, it is associated with increased cardiovascular mortality, increased risk of end-stage renal disease, and this non-dipping is quite common in CKD patients. Yeah. And what we do here is we just do this chronotherapy. That is, we prefer to give antihypertensive during night, which would decrease the incidence of non-dipping. And this, what is this riser? So what happens? Suppose the patient is hypertensive and despite of dipping BP during night, the BP rises during night. And these patients are also having increased cardiovascular mortality, increased risk of conversion to end-stage disease, and again these are quite common in CKD patients. Yeah. Now, what are the risk factors for hypertension? First of all, hypertension is of two types: primary, secondary. Secondary is that it is secondary to some organ damage like renal artery stenosis, renal parenchymal diseases, or endocrine causes like Cushing's disease. Okay. Primary means that there is no any organ related cause, and this is also known as essential hypertension. So what are the risk factors for essential hypertension? Risk factors are, first is age. We have already discussed that as age increases, the vessels become more and more stiffened, leading to increase in the systolic BP. Second one is obesity. Third one is family history. Then we have black race. Fifth one is increased sodium diet, increased alcohol intake, excessive smoking, physical inactivity. Okay. Now complications. Hypertension can lead to multiple organ involvement. Okay, and the complication can occur in any organ, mostly in CNS. Neurological complications are lead to increased risk of TIA, increased risk of CVA, mostly hemorrhagic, increased risk of aneurysm rupture, increased risk of dementia, vascular dementia. Okay. It can also lead to retinopathy, that is hypertensive retinopathy. And the grading of hypertensive retinopathy is stage 1 is arteriolar error. In the fundus of our eye, normal arteriole to venule ratio diameter wise is 2:3. When this ratio decreases, we have the stage 1 of hypertensive retinopathy. In stage 2, AV nicking occurs. In stage 3, copper wiring or flame shaped hemorrhage occurs. In stage 4, silver wiring of arterioles occur or papilledema can be there. Okay. Then we have serious complications in which LVH, coronary artery disease, heart failure with preserved ejection fraction, or diastolic failure, or increased risk of atrial fibrillation can be there. Okay. In vascular causes, aortic dissection or aortic aneurysm can be there. In renal causes, proteinuria can be there, conversion to CKD can be there. And hypertension is the second most common cause of end-stage renal disease, and it leads to hypertensive nephrosclerosis. And this is more common in patients having a POL1 genetic variant. Yeah. Now we have secondary hypertension. As we have already discussed that only 5 to 10% cases of hypertension are due to secondary causes, in which first is renal causes. In renal causes, we have renal parenchymal causes or renovascular causes. In renal parenchymal causes are diabetic nephropathy, polycystic kidney disease, glomerulonephritis. And the investigation that are used for these are urine analysis, KFT, and ultrasound. All of them. Renovascular causes, we have this renal artery stenosis, which can be because of atherosclerosis, most common cause. Then fibrovascular dysplasia, vasculitis, any tumor, or last is atheroembolism. And the investigation that is used for this is Doppler, renal artery Doppler, CT angio, MR angio, catheter angio, or plasma renin level. Okay. Then we have this endocrine causes. Here, and in endocrine causes, the first is Cushing's or hyperaldosteronism. The clue is that these patients would be having hypokalemic metabolic diseases. Yeah. Then we can have pheochromocytoma, in which episodic hypertension is there, and the trial is episodic hypertension, headache, and palpitation. The investigation uses 24-hour urinary metanephron. Third one is hypo and hyperthyroidism. Yeah. Fourth one is hypercalcemia. Hypercalcemia leads to stiffened vessels again, and which in turn leads to hypertension. Then we have miscellaneous causes, in which the first one is OSA, it is obstructive sleep apnea. Second is drugs like NSAIDs, steroids, OCPs. Miscellaneous causes, we have coarctation of aorta, in which there is hypertension in the upper limbs while BP is normal in the lower limbs. Fourth one is polycythemia vera. Now treatment. So this is very important part. As we have already discussed that in stage 2 hypertension, we'll start with 2 antihypertensives. Clear? Now, the importance of treatment is that every 10 decrease of systolic BP leads to decrease in CVS mortality by 20%, heart failure risk by 28%, and coronary artery disease by 17%. Yeah. Now, the first component of treatment is non-pharmacological. And in non-pharmacological treatment, each component can decrease BP by 5 millimeters. Okay. First component is weight loss. So our target BMI should be 18.5 to 20. And 1 kg loss in weight leads to 1 millimeter of mercury decrease in systolic BP. Yeah. Second component is aerobic exercise, in which 90 to 150 minutes per week of exercise should be done. Third component of non-pharmacological treatment is diet. The diet that is used here is DASH diet, called it as DASH diet, which there is more fruits and vegetables and decreased saturated and total fat. Fourth is low salt diet. Fifth is limit alcohol, cessation of smoking. Seventh is avoid insults. Yeah. Now let us discuss about the pharmacological treatment, and it is a very important component. We have a lot of drugs which are used as antihypertensives. The first line drugs in them are four only: ACE inhibitors, ARBs, thiazide or thiazide-like diuretics, and fourth one is calcium channel blockers, preferably DHP type of calcium channel blocker. Now, we have already discussed that we'll start with two drugs. Okay. Now, in this case, these four drugs, no one is superior to other. If the patient is having no comorbidity. If the patient is having any comorbidity, then we'll discuss that scenario later. But we'll first discuss the patient is having no comorbidity. The important thing to remember is beta blocker is not a first line drug. But if a patient is having angina or heart failure with reduced ejection fraction or migraine, then beta blocker can be used as a first line drug. Okay. Now, let us discuss treatment, pharmacological treatment in patients with no comorbidity. Now, patient is having no comorbidity, so we'll prefer first line agents only. First step is we should start A, that is ACE inhibitor or ARB, any one of the two, plus calcium channel blocker, and both should be started as low dose. If BP is controlled with this, then well and good. Otherwise, we'll increase the dose of ANC, full dose. Okay. If BP is controlled with this, then again well and good. Otherwise, we'll add thiazide-like diuretics. Okay. Again, if BP is controlled with this full dose of this, well and good. Otherwise, this is known as resistant hypertension. And in that case, we can add fourth agent, which can be spironolactone. Okay. Now, this is about a patient, a healthy, fit adult with hypertension. Now, we'll discuss about patient with comorbidities or specific conditions. So, in that cases also, we'll start with two agents, but in that condition, we will prefer some other agents too. Yeah. Like, first of all, suppose the patient is black or elderly or obese, then in that case, our first line agent should include CCBs plus thiazide-like type. Then second condition is, suppose the patient is having isolated systolic hypertension. Again, our choice should be CCBs plus thiazide. This third condition is, suppose the patient is having hypertension plus LVH. Then out of two drugs that we should give, ARBs or ACE inhibitor should be one. So out of ARBs or ACE inhibitor, we would be giving one drug only. We never give ACE inhibitor and ARB together. Yeah. Now, if a patient is having hypertension and LVH, then out of two drugs that we start, one should be ACE inhibitor or ARB because they prevent cardiac remodel. Yeah. Fourth condition is, suppose the patient is having hypertension and coronary artery disease. Okay. Then again, we'll prefer ACE inhibitor, ARB plus beta blockers. So in this case, beta blocker would be first line. Suppose the patient is having hypertension and MI. In that case, we'll give beta blocker plus ACE inhibitor. Suppose the patient is having hypertension plus tachycardia, then we'll prefer beta blockers. Or we can also give calcium channel blocker, but calcium channel here would be non-DHP. Okay. and we will give out one out of these. Okay, and the second drug can be any other drug. Okay? So beta blocker and non-THP calcium channel blocker should also not be given together because of the risk of AB nodal block. Seventh condition is hypertension plus aortic aneurysm. In this case, again, we will give beta blocker plus ARBs or ACE. Patient with hypertension and prior stroke will prefer ACE inhibitor ARB plus diuretics. Patient with hypertension and diabetes will prefer ACE inhibitor ARB as one agent and second agent can be any. In diabetes, we generally avoid non-selective beta blockers because they mask the signs or symptoms of hypoglycemia. In another scenario, hypertension and CKD, we prefer ACE inhibitor ARB plus diuretics. In another condition, hypertension plus BPH, will prefer alpha blockers like prazosin plus any other secondary. In patient with hypertension and migraine, will prefer beta blocker as it helps in prophylaxis of migraine 2 and any other secondary. In patient with hypertension and osteoporosis, we prefer one agent as thiazide and any other second agent as thiazides prevent the loss of calcium in the urine. Next slide. So BP goal. The target of our BP control is if a patient is diabetic, having ASCVD score of 10, more than 10%, is a case of known case of heart failure, CKD, or age is more than 65, then our target is less than 130 by 8. While a patient who is not having these comorbidities, that is low risk patient, our target is 141. Now let us discuss about individual drugs. First of all, we have this ACE inhibitor. Yeah. So we know that ACE inhibitors prevent the conversion of angiotensin 1 to angiotensin 2, leading to decrease in angiotensin 2 level. It also increases the level of bradykinin, which is responsible for the side effect of cough and angioedema. And this side effect is absent in ARBs, as they don't lead to increase in the bradykinin level as they directly block angiotensin 2 receptor. Example is ramipril. And the longest acting ACE inhibitor is pamintropin. This is the longest. Clear? Another important point is that ACE inhibitor plus ARBs should not be combined together. And ACE inhibitors are contraindicated in pregnancy. They are contraindicated in bilateral renal artery stenosis. And whenever we give an ACE inhibitor to any patient, rise in serum creatinine should be less than 30%. Normally, if it is more than 30%, we have to stop the drug. Clear? Another class of agent is ARB. Again, we have already discussed their mechanism of action. It is they block the receptors of angiotensin. They don't lead to cough and angioedema. Another point about ACE inhibitor is that they lead to hyperkalemia. But they should be given cautiously in patient having risk of hyperkalemia. ARBs again can lead to hyperkalemia like ACE inhibitor, but they don't lead to cough and angioedema. Another point about them is that losartan is one ARB, it has uricosuric effect too. So we can give them in patients of gout. Again, the telmisartan is longest ARB. Next class of agent is diuretics, in which we'll first discuss about thiazide diuretics, which is first line agent. Thiazide or thiazide-like diuretics. As we have already discussed that they increase calcium level in body, so we prefer them in osteoporosis. They inhibit the sodium chloride channel. Here. Now, the examples are hydrochlorothiazide, chlorthalidone, and metalazone. Out of this, only metalazone can be given in EGFR less than 30. And this is a very important MCQ question. Now, loop diuretics. They block sodium potassium 2 chloride channel in ascending limb of loop of Henle. One important side effect is ototoxicity, which is most common with ethacrenic acid. One important thing about loop diuretics is their conversion. That is 1 mg bumetanide is equals to 40 mg furosemide IV is equals to 80 mg of furosemide oral is equals to 20 mg of torsemide. So this is the conversion factor of different loop diuretics. Then we have another class of agent known as potassium sparing diuretics. They can again lead to hyperkalemia. So we use them cautiously in patients with increased risk of hyperkalemia. We have two types of potassium sparing diuretics. One is mineralocorticoid receptor antagonist, and another one is ENaC epithelial sodium channel. MRA we have spironolactone and aplenerone, while in ENaC blocker we have triamterene and amiloride. Now spironolactone or aplenerone, these are preferred in patients with heart failure as they prevent cardiac remodeling. And they are the preferred diuretic in cirrhosis with ascites. One important side effect of spironolactone is gynecomastia. Another class of agents is calcium channel blockers. Calcium channel blocker, we have two types of calcium channel blockers, that is DHPs, non-DHPs. Calcium channel blocker inhibit L type of calcium channel. In DHPs, examples are ifedipine, amlodipine, nicardipine. So what happens is that these agents are more active peripherally. So they leads to peripheral vasodilation, and which in turn leads to reflex tachycardia. These agents are preferred in hypertension as this leads to peripheral vasodilation. Non-DHPs, CCBs, they have more effect on cardiac tissue, so they leads to bradycardia and decrease contractility and blocks the AV node. While their peripheral action is minimal, that is, they don't lead to peripheral vasodilation. So non-DHPs, CCBs are mostly used in patients with tachyarrhythmias. They are not good antihypertensive agents. while DHPs, CCBs are preferred antihypertensives. One important side effect of this DHP CCB is beta-lactam, as they lead to peripheral vasodilation. And another side effect of all CCBs, that is DHPs and non-DHPs, is constipation. Another good thing about non-DHP CCBs is they decrease proteinuria. So they can be used to decrease the protein. Then we have beta blockers. As we have already discussed, that beta blocker is not a first line drug, but we can give beta blocker in patients of heart failure, coronary artery disease, and angina as a first line drug. Okay. Now, beta blockers, especially non-selective, should be avoided in young patients, should be avoided in patients of type 2 diabetes, and should also be avoided in patients of COPD, as it can lead to bronchospasm. And in patient of diabetes, it would lead to masking of the signs and symptoms of hypoglycemia. We can also use alpha plus beta blockers like carvedilol or levodopa. Okay. We can use this alpha blocker, that is prazosin, and it is mostly preferred in patients with BPH plus hypertension. Side effect is postural hypertension, which is also important question. It is asked sometimes. Here, the dose of prazosin is 2 to 20 mg per day. Then we can also use the central alpha agonist like clonidine or methyldopa. Their side effect is it can lead to withdrawal or rebound hypertension. Yes. One important thing about methyldopa is, and it is also a frequently asked question, that it is quite safe in pregnancy. So it can be given to pregnant female with hypertension. Another important point is its side effect is autoimmune hemolytic anemia. It is also important. See? Now, next class of drug is other vasodilators, which we have two important vasodilators. One is hydralazine, another one is minoxidil. Their side effect is headache, fluid retention, and reflex tachycardia due to vasodilatation. Now, another entity is resistant hypertension. We have already discussed about resistant hypertension, that is, if hypertension is resistant to 3 or more than 3 antihypertensive agents, and including one of them should be a thiazide or thiazide-like diuretics. Okay. Or we can also say that if it is controlled on 4 or more than 4 agents. Clear? Now, if we have this patient of resistant hypertension, then first thing to do is exclude secondary causes of hypertension and to decrease salt intake and to rule out poor compliance. Yeah. After this, how to manage resistant hypertension is First of all, we have to ensure effective diuresis. So we have to ensure that we are giving full dose of thiazide diuretics, and after giving full dose of thiazide diuretics, the patient is not having diuresis, then we can add spironolactone or loop diuretics. Then second point is to ensure adequate RAS blockage. Then after this, we can add other agents like beta blockers, alpha blockers, or other vasodilators. And we can also do is chemotherapy, chronotherapy. That is, we can give these drugs during night. Again, if patient BP doesn't control on all of these agents, then we can do renal denervation. Or we can also do baroreceptor pacing. These are the new antibiotics. Now, another important topic is hypertensive urgency or emergency. Basically, when BP is more than 180 systolic by 120 diastolic, clear, then we call it as hypertensive urgency. Now, if this is associated with end organ damage, then we call it as hypertensive emergency. Okay? So if end organ damage is not there, then it is hypertensive urgency. If end organ damage is there, then it is hypertensive emergency. Okay? Now the treatment here is we can give nitroprusside, we can give nitroglycerin NTG infusion, we can give IV labetalol, we can give IV nicardipine, and we can give enalapril. Basically, enalapril is a ACE inhibitor and it is an oral drug, but enalapril is IV formulation. Now, suppose if patient of hypertensive urgency or emergency is having these associated features, like patient is having unstable angina, MI, or dissection. Along with this hypertensive urgency or emergency, then we can give esmolol too. Patient is having ADHF along with hypertensive emergency or urgency, then we can give IV loop diuretics. If patient is having adrenergic crisis, then we can give phentolamine. If patient is having preeclampsia, then we can give IV hydralazine. So this sums up our class on hypertension. We'll soon come up with new class. Till then,